We're online. We are good to go now, sir. Hello.
Let's start, Bhuvan.
Yes, sir. We can start now, sir.
Good evening, doctors. Welcome to this webinar on experience sharing program. This program is brought to you by Hetero Healthcare. Hetero Healthcare has 25 years of excellence, 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. It's among the largest manufacturers of ARV, APIs, and FDFs in the world, and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360 degrees solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Experience Sharing on Managing PPH, we have got Dr. Kanchan Kanjilal with us. Welcome, sir. Welcome to this program. Dr. Kanchan Kanjilal, sir, is MBBS from Calcutta University from 1986 batch. Sir has done his MD in Obstetric and Gynec from Sambalpur University 1992. MRCOG from Royal College of Obstetrics and Gynecology from London 1997. DFFP from Royal College of Obstetrics and Gynec London 1999. Sir has undergone USG training in Obstetrics and Gynec, started in NW Hospital, Mumbai in 1990, USG practice and continued in all hospitals during MD and MRCOG courses in Sambalpur, India and UK for 3 and 7 years respectively. Sir has been presently practicing as leading consultant obstetrician and gynecologist at Kolkata over last 1.5 decade and is consultant at Swapnadeep Clinic. With this brief introduction, I hand over the session to Dr. Kanchan Kanjilal, sir. Sir, welcome once again to this program. I stop sharing, sir. You can share your slides.
Okay, so I'll just
Yes,
take
sir.
a time bit to get adjusted.
Yes,
So
yes.
sharing, Dr.
Yes.
Prashant is here, so this will be my part, right? So this is the part which I am sharing now. Okay, I believe you can see me. I mean,
No, sir, not yet. Yes, we can see now.
You can see the
Yes.
slides. Okay,
Yes,
this
sir.
is the
Yes,
beginning
sir. Very
part.
much.
So going ahead after that, after the introduction of the nice introduction of me, so I'm going forward for
Yes,
the
sir.
slides, right? Okay.
Yes, sir.
So next is your. Let's start moving.
You can put it in the sharing slide, sir.
Yeah. It's already sharing. Your screen being sharing, that it says, right? So it should move ahead. No, it's not moving. That is the first one. The next one is this one, right? So you can see me.
Yeah.
The overview of the postpartum hemorrhage. We'll be going through this program. This is basically a discussion about the postpartum hemorrhage, the effective management of the postpartum hemorrhage. You can see me. The video is on, I believe.
So we don't see you, but we can see your slides.
All right, fine. That is enough. You don't need to see me, right? So this is the discussion about postpartum hemorrhage, effective management of postpartum hemorrhage, or the modern management of postpartum hemorrhage, you can say. We as obstetrician always manage these kind of things and try to prevent things happening rather than managing the things once it happens. So the whole idea is prevention. And as we all know, that prevention is always better than cure in medicine. So this is the thing which we'll be highlighting now with this discussion. So next one is so overview. Next one is right, postpartum hemorrhage. This is a daunting event, as we have discussed that this is a very important event. All of us face this as an obstetrician, but there is always some kind of hemorrhage occurring after the delivery of the baby, and that hemorrhage is physiological hemorrhage. And as long as it is within a certain limit, it is not of concern. But if it is obviously crossing the limit, which is defined as 500 ml in vaginal delivery and 1000 or 1 liter following cesarean section, then it's of concern. And obviously, this is a potential dangerous thing which can even endanger the life of the mother if it is not taken care of properly. So this is the background, obviously, and that we always try to avoid this thing happen. That means the bleeding going beyond certain limit. So the next one is your. This is the statistical bit of it. On obviously, statistics says that it is a maternal mortality leading cause. This is leading cause of maternal mortality all throughout the world. But the developed world or the high resource world has solved this problem to a great extent, where the middle group or the lower income group of countries are yet to solve this problem completely, so that the maternal mortality is still affecting us, and is about 35% of the maternal mortality deaths is through this avenue. MMR or maternal mortality in developing countries was 240 per 100,000 live births compared to 16 in developed countries or high resource countries. So this was the statistics perhaps before 2020. Now we are getting better day by day, and the present statistics is less than 100 per 100,000 live births, which is after 2020. So this is an important milestone going on, but the aim for India is to get it down to 70 or perhaps less than that by 2030. So with that ambitious things, we are giving more and more importance to prophylactic care of the PPH happening. This is the background statistics we have to remember. Coming to the etiology, why postpartum hemorrhage happens. This happens because of this play of these factors like tone. The uterine tone is the most important aspect, because these after the delivery of the baby and the after birth, that means placenta and membrane, the tone of the uterus controls the bleeding happening, going beyond a physiological level. So that is the uterine tone, which is increased, which is physiological, then the postpartum hemorrhage will not be affecting us in any way. The other associated factors which can affect the postpartum hemorrhage happening is thrombin mechanism, because whatever bleeding is whenever there is bleeding, the bleeding is stopped actually at the microscopic level, at the biochemical level, with the play of this formation of this thrombin coagulum. Once they are formed adequately, the bleeding stops. So adequate thrombin formation is also a prerequisite for postpartum hemorrhage control. So if that is not adequately formed, that means there is coagulopathy happening around to some extent. This will be contributing the postpartum hemorrhage. And in the vaginal tract, or in the uterine in the birth tract rather, in the uterus or the vagina or associated regions, there is trauma which is leading to bleeding that can obviously contribute to postpartum hemorrhage. So uterine trauma, injury to birth canal, rupture, uterine inversion, and lacerations, these are all reasons for having the postpartum hemorrhage affecting the health of the delivering mother. And any tissues like afterbirth membrane as well as placental bits remaining behind inside the uterine cavity will contribute to this postpartum hemorrhage, because anything left behind in the uterine cavity after the delivery will hamper the uterine tone to occur in an adequate way, in a physiological way. That means we are always taught with that fact that that empty uterus never bleeds. So we have to make sure that the uterus is empty following delivery. So unless this is happening, there will be chance of postpartum bleeding. So this interplay of facts of tone, thrombin, trauma, and tissues all in T's is an important factor. But the most important is obviously uterine tone. If the tone is physiological, tone is adequate, then the bleeding will not be affecting us. So once the clinical situation of postpartum hemorrhage is there, then certain findings will be obviously of importance. And these findings in clinical practice, we always get one after another happening if it is not arrested adequately. Obviously, the uterine tone is less, then obviously the uterus will be feeling not toned up, not formed, not well contracted, which means the boggy feeling, abdominally feeling the boggy feeling of the uterus, which means if any vessel filled with any bloodary tissue is filled with some fluid, and if we can feel that, there will be the bogginess, which is a typical of a balloon filled with some water. And if you feel it from the top, that bogginess is possible to be felt in a postpartum lady when you felt abdominally. So there will be tenderness on the abdominal part, and because all this happening is because of the bleeding continuing. So there will be vaginal bleeding more than usual, more than normal. Because of these things happening, there will be compensatory mechanisms also taking place, and there will be maternal tachycardia. There will be also at some point the compensatory failures. There will be shocks. There will be loss of blood pressures and all this. And this chart, this table is telling us at what point of time you are getting which kind of response. That means the blood loss, if it is more than physiological, that is 10 to 15% of blood loss. If it is within the physical limit, the blood pressure will be remaining normal. There will not be much of changes in there, but there will be palpitation, dizziness, and tachycardia to some extent. When the bleeding is more, that means 1000 to 1.5 liter, 1000 ml to 1.5 liter, which is 15 to 25%. There will be signs that blood pressure will be falling to 80 to 100 millimeter of mercury in the systolic component. And there will be weakness feeling, there will be sweating, and there will be compensatory tachycardia also. But as the bleeding goes on the higher side, that means the loss is moderate, 1.5 liter to 2 liter, which is 25 to 35% of the blood loss happening. There will be more blood pressure loss, which is 70 to 80 millimeter of mercury in the systolic component. And obviously, proportionately, the diastolic component will be also less. And there will be obviously more sinister symptoms occurring. The patient will be restless, the patient will be having more pallor, and patient may even have oliguria. And in severe cases, when the blood loss is 35 to 45%, there will be profound fall in the blood pressure, and obviously patient can go to collapse stage, and with air hungers and urea even. And if it is not managed adequately, the life may be in danger. So that is an important stages which goes through in the physiology and in the pathophysiology of the development of the PPH and its after effect. So obviously we'll be aiming not to have that kind of serious things happening, but in clinical practice, often patients are brought from outside where you can have this kind of feature presentation with this kind of features, and that needs to be managed very aggressively with an adequate backup from all the departments concerned. That means anesthetists, that means circulatory, that means blood bank support, that means obstetrician, and even surgeons should be around, and intensivist people, and a good amount of helping hand is helpful to get out of this sinister situation. So how you are diagnosing? Diagnosing by initial evaluation, which we have just enumerated a bit amount. So rapid assessment of the patient status is important, and presence of tachycardia and hypotension is to be noted, and assessment of the vital signs and blood loss to be done quickly. Side by side, the resuscitation process goes on, and we examine the the time of the hemorrhage, assessment of the entire genital tract for lacerations, that means trauma aspects, whether there is any evidence of trauma with the presence of lacerations, hematomas, or signs of uterine rupture or uterine inversions kind of thing. Manual examination is important, and manual examination can tell us about the retained placental tissue, and obviously that is to be removed quickly. Assessment with bedside ultrasound to check out of the uterus is necessary when it is available. The evaluation of the uterus to check for uterine inversion. This is all possible clinically and can be done with good teamwork. And obviously, you send some blood and other tests to check out blood count, to check the hemoglobin and the hematocrit and platelets counts. Coagulation profile also can be done simultaneously. So this gives us a complete picture of the patient which is presenting with this situation. And obviously, the management goes on accordingly. Like if you find poor uterine tone, the clinical findings will be accordingly there, as I have said before, like your uterus will be filled. Just a minute, go for this mode. Yeah. So there will be poor uterine tone. Obviously, the abdominal palpation will be telling us about this bogginess and soft finding of the uterus. You find out the uterus fundus, that gives an idea of the internal hemorrhage happening. And investigations once done gives us a better picture of what is we have to manage. The management obviously is by uterotonic agents and any genital trauma which is discovered, to repair that as quick as possible, and obviously hemostasis to be achieved as quick as possible. Replacement with blood is also most of the time is necessary with PPH. Once there is presence of trauma detected, that is to be repaired on an urgent basis, and need of anesthesia obviously at this point comes in. This is true with retained tissues also, which is to be removed by manual removal method when you need to have a good view inside, and also may use to use your hand to remove the products that is retained placenta or partially retained placenta manually. So once these are done on an urgent basis, the fluid replacement has to be made, and once the fluid replacement is made adequately, the patient becomes stabilized gradually. And obviously that may take sometimes a day or two. Once there is no fallout effect or complications associated with that, the patient's recovery will be obviously quicker. But if there is associated damage to organs, that need to be taken care of. So medical, surgical, anesthetics, blood bank, nursing, obviously hands are very important while these types of management is done on an emergency basis. So we have talked about this prophylaxis. The prophylaxis is very important, and with prophylaxis comes the use of the medical use of agents which are in common practice, like oxytocin, ergometrin, and then obviously misoprost and prostaglandins, and most recently this carbetocin. Carbetocin basically is an oxytocin analog, but giving more half-life and more effective functions. So carbetocin is available as a room temperature stable formulations, and that is very important. Initially, when carbetocin came in market, it was not heat stable, and the same problem happened with carbetocin also, as we face that room temperature problem, because if you are not stabilizing this with the temperature below 30 degree, maintaining cold chain, then this will not be of effect. So in resource poor situations, use of this kind of thing is not sometimes possible. So if you take away the temperature aspects, that means it is stable in room temperature, then that becomes very easy to use. So carbetocin gives an edge above oxytocin with these characteristics. So oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation. Heat-stable formulation of oxytocin is currently not available, and previous formulations of carbetocins had the same problem with the need to store at 2 to 8 degrees centigrade. So obviously, resource-poor countries sometimes cannot manage that, and thereby the effectivity of the molecule is reduced. Whereas carbetocin is stable at room temperature, has a half-life of 24 months at 30 degrees centigrade and 75% humidity. It avoids the need for cold chain storage and logistics. Obviously, that is the greatest advantage. It is provided in a vial. So this is the main plus point, so to say, about the carbetocin thing. So we are used to use lot of uterotonic agents, like as I said previously, this oxytocin molecule, and now this carbetocin most recently is with us. Argometrin is ergot alkaloid, and symptometrin is a combination of these, argometrin and oxytocin, and obviously misoprostol. So it can be uterotonic agents are used depending on the timing. That is a very important issue. How you're using the uterotonic agent, and the timing becomes a very important issue there. It can be administered at crowning. It can be administered at the delivery of the anterior shoulder, and at the end of the second stage of labor, and following the placental delivery. These are the four timings where you can use these uterotonic agents, depending on the molecule and depending on your practice and the clinical situation. Prophylactic use, or to prevent the things happen, that means to prevent PPH happening, the active and inactive management of third stage of labor, and therapeutic use when the things has already happened, that means the patient in PPH and you are managing that, that is the therapeutic use. So we'll be discussing about carbetocin mainly on this line, which is prophylactic use, because carbetocin is used for this purpose of prevention of PPH to happen in vaginal as well as cesarean section deliveries. Whereas other molecules can be used for other purpose, but carbetocin has got this strict indication. And in this indication, if it is used properly, that gives a good response and perhaps an edge above oxytocin if you can use it properly. But financial aspect is obviously carbetocin is lagging behind oxytocin, which we'll be discussing, which you all know, because carbetocin is about 10 times more costly than oxytocin. I mean, one vial of oxytocin, 5 units, is giving within 25 rupees 25, whereas carbetocin is 250 to 350 or even more than that in different situations. So cost-wise, it's a disadvantage, but the difference is not much because you're not using multiple ampoules of carbetocin, because one ampoule of carbetocin of 100 microgram is giving you doing the job. So financially, it is probably comparable when you are using multiple ampoules of oxytocin, but vial to vial is obviously is costlier. So those are the uses of uterotonic agents. And now if you look at the molecules of oxytocin and carbetocin, you find that carbetocin has got has got 3 modifications, I think. If you look at the molecules, then it has got this thioether bridge, which is the NH2 SS bond is absent in carbetocin. The SS bond is being replaced by SH bond, which is an advantage. This is a thioether bridge we call. That gives, this is one change which has occurred in this molecule of oxytocin to carbetocin. Carbetocin also has got the deamination done. That means the amino group is being replaced here. And the third change is O-methylation. This O-methylation is absent in for the O-methylation. These three changes gives this molecule more stability and more effectivity as compared to oxytocin. Obviously, this is a synthetic analog of oxytocin and is a long-acting analog of oxytocin. So these are the three molecular changes which has made it that kind of stability. This reduces the enzymatic degradation which oxytocin as well as carbetocin faces with the help of the aminopeptidase enzyme. So the carbetocin has become more resistant to aminopeptidase degradation because of these three molecular changes as you compare to oxytocin. So this is synthetic long-acting analog of oxytocin. This is mainly used for or only used for prevention of the postpartum hemorrhage due to uterine atony. Obviously, the other things, the trauma, the retained products, the coagulation problems, the thrombin, those three T's, these are the separate tissues and has to be tackled separately. But when tone is the cause, then you have to prevent it most effectively with the carbetocin. So carbetocin was created by making several modifications to the oxytocin structure as we have outlined. Now, as you go for the clinical evidence, you find that the efficacy and safety of the carbetocin, comparing this with oxytocin, because oxytocin is the age standard or gold standard perhaps of prevention as well as induction and all induction of labor, augmentation of labor, prevention of PPH as well as treatment of PPH as a gold standard molecule. If we compare with that of oxygen molecule versus carbetocin molecule, carbetocin is non-inhibitor, is not inferior to oxytocin. That means it is as comparable to oxytocin, and as I said, is perhaps better than oxytocin. This is proved in WHO champion trial, where this has been beyond doubt established. Carbetocin decreases the need for uterotonic agent. So once you give one injection or one ampoule of carbetocin, the subsequent need for using further uterotonic agents arises very rarely. Single dose of carbetocin is obviously better than continuous infusion of oxytocin, because one dose of carbetocin acts longer as compared to one dose of oxytocin if you apply intramuscular or intravenous, either way. Oxytocin effect is gone by 30 minutes perhaps, and whereas this carbetocin may continue to affect, give rhythmic contractions up to 120 minutes. So the need for continuous infusion of oxytocin is not there with the single dose of carbetocin. And comparison of carbetocin with oxytocin with respect to reduction in the blood loss and need for other interventions. Efficacy and safety of carbetocin will be also done with vis-a-vis comparison with symptometrin. So if you go to the next part, so this is the characteristics as you find. Okay. This is the characteristics of oxytocin as compared to a heat stable carbetocin. If you compare, these are both are hormonal effect, both are giving, both are synthetic, oxytocin as well as carbetocin. The oxytocin binds to the oxytocin receptor in the uterine myometrium. stimulating contraction of that uterine smooth muscle by increasing the sodium permeability of the uterine myofibrils. That means that at cellular level, that at the membrane level, it gives increased permeability of the sodium, and thereby the sodium potassium channel is activated more and giving influx of the ions inside the myofibrils, which effectively contracts. So this is the basic mechanism which is stimulated by oxytocin, and also the similar way carbetocin also act the similar way, but the contractions of carbetocin is more strong and more persistent and more frequent. So this is the advantage over oxytocin of carbetocin. The single dose of carbetocin gives you more persistent effect. Pharmacokinetics, if you compare intravenous IV, almost immediate action starts with oxytocin. It peaks in 30 minutes. If you compare it with carbetocin, then that the action also starts with a minute, but lasting for about 6 minutes and followed by rhythmic contractions for 60 minutes. So this is an important issue, that the duration of action with the help of the rhythmic contraction is double of oxytocin. If you compare intramuscular applications, then intramuscularly, oxytocin takes about 3 to 7 minutes, but produces a longer lasting clinical effect up to 60 minutes, where the half-life is 6 minutes. If you compare the half-life, then carbetocin gives a much longer half-life of 40 minutes. Intramuscularly, sustained uterine contractions are lasting about 11 minutes, and the rhythmic contraction goes on for 120 minutes. So this is a long time, which you get with single injection of intramuscular injection of carbetocin. Storage and transport. Oxytocin requires protection from light, and the storage is needed at 2 to 8 degrees continuously to preserve its activity or potency. If that chain is broken, that means the temperature chain is not maintained adequately, obviously the effectivity of the oxytocin ampoule reduces. That demands more doses of oxytocin, and obviously less action of the oxytocin is clinically found then. And with carbetocin, the temperature storage conditions may be up to 30 degrees centigrade without any loss of effectivity. Oxytocin can be used in all the situations: induction of labor, augmentation of labor, prevention of PPH, as well as treatment of PPH. But heat stable carbetocin has got only one indication, that is prevention of PPH, and in that category it works fantastic. But it should not be used for induction of labor, for augmentation of labor, for treatment of PPH, for obvious reasons, because these contractions, which are more persistent, more strong, is not ideal for induction of labor, and also for augmentation of labor. The effect of this carbetocin on baby is not tested, and obviously that kind of contraction may lead to damage in the, reducing the circulatory effect on the circulatory effect, reducing the blood supply to the baby, and which may be a disabling situation, may even lethal situation. So it is not to be used for the induction of labor and augmentation of labor. And the treatment of PPH, there also carbetocin is one step behind oxytocin, because its effectivity there is not also proved. Like we mentioned about the champion trial, it is basically carbetocin hemorrhage prevention, and the largest clinical trial in the prevention of PPH, trial conducted by WHO, Department of Reproductive Health and Research. The study design, non-inferiority, double-blind randomized trial. Objective was to compare the effectiveness of the safety of investigational heat-stable carbetocin with oxytocin in the prevention of PPH after vaginal birth. And patients enrolled around 30,000 patients across 10 countries, and India also participated in that trial. Primary outcome was the proportion of the women with blood loss of at least 500 ml or the use of additional uterotonic agents. The proportion of the women with blood loss of at least 1000 ml. That means 1 liter. Now, if you look at the table, you find that blood loss less than 500 ml, carbetocin efficacy was 14.5%. Oxytocin has got the similar efficacy. And the use of additional uterotonic, a similar kind of efficacy is found with carbetocin as well as oxytocin. The safety, at least one unanticipated adverse effect was safety was 4.9% with carbetocin, and oxytocin has got similar episodes. So the comparison is neck to neck, and the result is obviously carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. So that is the conclusion of the study. And this Cochrane review also given us the similar kind of outcome. In this Cochrane review data from 11 studies involving 2635 women, the author concluded that for women who undergone a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to centometrin in the prevention of PPH for women who have vaginal deliveries, and is associated with significantly fewer adverse effects. So that is an important observation as is found in the Cochrane database. So the guideline recommendation all over the world, they mention that carbetocin can be used successfully, and all the governing bodies has given a green signal for this. Very interesting to note that Japan and states are not using carbetocin, but apart from that, many countries are using carbetocin. In fact, Canada and UK were using carbetocin for PPH prevention, perhaps first globally. That was way back. But we subsequently picked up this thread once the WHO and FIGO started recommending this carbetocin used for PPH prevention management. So this is the graph. This is the diagram showing us an authority and giving us that recommendation to use carbetocin whenever possible for better effect for prevention of PPH. So this is, I think this is not only my experience, I think it's experience of all the obstetricians who are using carbetocin, that this is smarter, superior, perhaps, and safer choice in PPH management, because you are not using multiple doses, you are giving one dose, and that one dose is giving you long-lasting preventative effect. It is not to say that you cannot use additional uterotonic agents if required, but the incidence is very less. And just to mention that there is synergistic effect of prostaglandins, misoprostol, and as well as prostaglandins when there is need to use even after carbetocin for PPH. So that is an important observation, and we have used in our clinical practice those things very rarely, but obviously use that. But carbetocin, in most of the situation, giving single dose at the right point of time of delivery gives you fantastic coverage to prevent the PPH happening. But always remember, if there is genital tear, a genital trauma, or there is retained product inside, that has to be taken care of. That means that product has to be removed, as well as that tears and traumas has to be repaired, so that the other T's, that means, and also coagulation problem, anything have around, that has to be taken care of. That means thrombin, that means trauma, and that means those products remaining inside has to be taken care of, apart from giving agents like carbetocin. So carbetocin is a fantastic molecule. If you can use that, then you get the benefits of carbetocin, but has to be used in a right moment. And it is used not only in singleton pregnancies, not only in vaginal delivery, but also in twin pregnancies, as well as in complicated situations like preterm labors or preterm deliveries, or where uterus is more distended with the help of either twin pregnancy or polyhydramnios or big babies like situations. And in all those situations, carbetocin also gives you good result, and obviously that is an important armamentarium in our use of uterotonic agents to prevent PPH happening. But remember that if needed, after carbetocin also we can use oxytocic agents like carbopostrophethamine, which is prostaglandin, as well as misoprostol, to give synergistic effect to control PPH. So these are the things which I believe is important points to remember while discussing about PPH with the help of prevention of PPH with the help of carbetocin. That concludes, I think, my situations, my words to say to the audience, and I think Dr. Prashant is eagerly waiting to take over and give his inputs about this issue. Dr. Prashant.
Yes, thank you so much, sir. We'll not take those questions. As you said, you have discussed all this. Thank you so much for your sharing your experience. I'm sure the audience has benefited out of your sharing your experience. And once again, thanks for joining and taking a webinar on the benefit of carbetocin, your experience with carbetocin. Thank you so much, sir. Thanks the IT team. Thanks sales and marketing team of Hitro for coordination. And thanks all the doctors who took time from their busy schedule and attended this webinar. Thanks so much, sir. Sir, you can log off, sir.
Thank you. Thanks for your help. I'm just thinking, will you tell something about carbetocin's benefit in your own
Sir,
experience?
I think you have summarized well, sir. You have summarized very well.
Right.
And your own clinical experience is more important than our academic.
Yes, I understand. Applied part is always better than the abstract part.
That's exactly what doctors want, sharing our own experience.
Yes. Okay. But I believe that abstract part is important, because unless you have got good abstracts in your mind, then you cannot apply things in an effective
and your
way.
experience shows, sir, you have used it adequately. You have shared your experience. You shared the pluses and limitations of the molecule also. It's very great. Thanks so much once again.
Thank you. Thanks for your help. Thank you. And thank you, everybody.
Yes.
Hetero team.
Sign off, sir. Thank you.
Okay. Thank you.
Thanks, Bhuvan.
Thank you, sir.
Thank you.
Thank you.